Baljeet, go ahead and introduce yourself.
Afternoon, everyone. Baljeet Handon. I'm a CWDA consultant working on Cali.
And formally with?
Oh, yes, and formerly with Mariposa County. I see some of my Mariposa former colleagues in the chat, so good to see you guys.
Andrea, why don't you go ahead and introduce yourself as well?
Oh, sure. Hi, I'm Andrea Sobrato with CFPIC. I'm a senior associate there, responsible for capacity building and strategic integration. And I also want to announce that our executive director, Stuart, is on the call as well. I was wondering, Stuart, if you could introduce yourself.
Yeah, hi, Stuart Oppenheim, the executive director at CFPIC, and pleased to be partnering with everybody to make sure that you get this fabulous information. So back to you.
Thanks. So I want to just introduce the team real quick, just so you know that we have been partnering with CFPIC. We brought on Baljeet because we know the importance of supporting counties and the importance of the CalAIM initiative. And I'm not going to say why that's the case, because you're going to have two great presenters walk you through why that's the case and why we're leaning in on CalAIM. And so I don't want to, without much further ado, because we have a packed agenda and great information to share with you. So I wanted to just really quickly introduce and welcome Alex Briscoe. He's the principal at the California Children's Trust. They put out fantastic publications. If you're not signed on to their distribution list, I welcome you to do that. Also with the Public Works Alliance and a former director at Alameda County Health Services Agency. And then we also have Sarah Arnquist. She's a principal consultant for SJA Health Solutions, has great experience in Medicaid policy, behavioral health systems, and works very closely with Alex. So I think with that, Alex and Sarah, we're just going to go ahead and turn it over to you.
Hi, everybody. I had a mentor once tell me we're all better when we act on the exhale, which I kind of like. So we're going to dive deep into a bunch of Medicaids. And if that makes you a little sick to your stomach or angry, I know where you're coming from. But I'm going to sort of suggest that child welfare can't get where it needs to go if we don't get Medicaid right, you guys. So I know there are so many wounds and there's so much water under the bridge, like referring kids and being told they're not sick enough or not being able to find the services they need. So I just want to acknowledge that, nobody's here telling you that it's all good, okay? It's really stinking hard. And I also want to say, well, first, thank you so much for the work you do. I spent a lot of years in public service. It left me very sad and frustrated, but also I'm deeply respectful of the challenge before you. And the good news is things are changing. There's a bunch of new stuff happening. So I'm not suggesting you ignore all of the challenges and drama of the past, but join me in a little hope. And I'll try to convince you Medicaid is sexy. Whether you can go with me down that road or not is up to you. Sarah, it looks like we're having some version control on the deck, so maybe I'll just run the first set of slides and switch over to you. Great. Yeah.
And you are able to share, there you go. And I should have added to that, we're going to have Alex and Sarah do most of their presentation and try to hold questions to the end. But Alex and Sarah will monitor the chat and answer those questions, some questions potentially along the way too.
Yeah.
So, yeah.
And just heads up, y'all, we're going to get deep into the weeds. But I'm going to start with trying to convince you that there's gold in Dumdare Hills and it's time to put your hope hat on. But we're going to actually take you through the MOU and the details of the additions we recommend. So we're going to dive deep into the weeds, but start with me a little higher up. I'm trying to make the case for Medi-Cal. And then we're going to take you through the design of the structure of the MOU and some key strategy considerations. For those of you who don't know, we are formally working in 4 counties, LA, Fresno, Ventura, and Santa Cruz, but we don't believe in intellectual property and social justice work. Everything we do is open to everybody. So that's the origin of the MOU. We'll show you they were prepared specifically and co-crafted and co-created with county leaders. Yeah, So just so you know where this work comes from. You can't do this work without Medicaid, and finally Medicaid is changing. For more than a decade, I led one of the state's largest healthcare systems, and I would go up to the state and say, this is messed up. What are you asking me to do? And I would be repeatedly told, it's your fault, go back to your county and do it better. And what I can honestly say is that it's not what's happening now. Now there is a universal agreement, political will, that the nation's largest Medicaid program needs fundamental change. So if you want to see like the forest through the trees, Cal AIM and the Youth Behavioral Health Initiative is an acknowledgement at the state level that the nation's largest Medicaid program sucks and needs to get redone. And that is following what Californians say is most important to them, which is the social and emotional health of their children. And we are finally now talking formally and directly about racism, poverty, and adversity in qualifying for care. We are now living in a new world order of Medicaid, where you no longer have to have a diagnosis to access care, and where you qualify simply because you have interacted with the child welfare system. You've experienced discrimination. You have housing instability or food insecurity. But to take advantage of these changes, we have to adopt a paradigm shift, an internal shift that says mental health is not a response to pathology. It's a support for healthy development in an increasingly toxic culture. And for the young people and families you serve, their lives are filled with adversity and structural burden. And Medi-Cal, if done right, is an essential funding strategy for expanding on the work you do with parents and better meeting the needs of the children in your care. And why is Medicaid or Medi-Cal so important? Because every single child serving system in the state of California works the same way. There's a federal law tied to a state enabling action, but it's administered at the local level. That's true of child welfare. It's true of juvenile justice. It's true of early childhood. It's true of education. It's true of the regional center. Like it or not, good or bad, Medi-Cal is the tie that binds. Meaning if we're going to transform these child serving systems to be more healing centered, they are going to need new money and resources to do it. But we have to acknowledge that the medical model may not be the way forward. So Medi-Cal has to change, but the pace it's going to do its damage, or good damage, its good trouble, is going to be in the child serving systems that it supports. So as we begin to talk about the opportunities in the landscape and specifically how to codify them in the MOU, I just want to set some terms so we can be talking about the same thing. We're trying to call this the child welfare continuum after having talked to lots of child welfare leaders. So thank you to many of you on this call who helped inform this structure. But when you talk to managed care plans, they think of child welfare as kids. But we know that your work has an entire continuum, from working from left to right, from your prevention plans and community pathways, upstream prevention, from your family maintenance, family unification, and differential response programs, your parent services, and finally, tailored services for kids in care. So one of the key strategic understandings that you need to bring to your negotiations with the managed care plans is they're going to be solely focused on the kids in care, and you need to open up their hearts and minds to partnering with you on your prevention, sustaining your prevention plan and building your community pathways, and in enhancing your FM, FR, and differential response programs. Because something like 90% of all families who interact with the child welfare system were eligible for Medicaid when they first made contact. Like, rich people don't lose their kids, poor people do. So understanding this entire continuum, you'll see our work in the MOU tracks to all three of these child welfare Medicaid impact areas, and each one's slightly different. The good news is you all in child welfare are focused on these upstream opportunities to prevent child welfare system involvement, and finally Medicaid is coming around to investments in things specific to the social determinants of health. So there are literally new benefits focused on housing, focused on care coordination, including respite care and others that are focused on what actually drives poor health outcomes, which has very little to do with traditional diagnostic criteria and everything to do with how safe your community is, with how good your housing is and how much money you make. So The hope addict in me says, wow, child welfare and Medicaid are finally talking about the same stuff. Maybe we can bring them together to scale new resources to do better work. 80 or 90% of children with an open child welfare case come from families under 266, 268. That's actually the number for Medi-Cal eligibility in California. It's super important to note that we finally live in a state where all low-income folks qualify regardless of immigration status. So if you remember, in 2015, we added kids, then we did the young adult expansion to 26, then we did the older adult expansion, people over 50, and January 1st, 2024, we added the 50s, the 26 to 50s. So now all low-income people in the state of California, regardless of immigration status, qualify for Medi-Cal. Like Baljit and many others, I'm sure this has been like me, have been working on this topic for many, many years. Thinking about the kids in care, we have to acknowledge that not all are Medi-Cal managed care beneficiaries. Okay, so I'm now just talking about the right-hand side of that continuum. Meaning, if you are in a single plan county or a county organized health system, kids get right in the plan. They're either in Kaiser or your plan, your public plan. But if you're in a multi-plan county, which is more than half of all kids, most of those kids are in fee-for-service, therefore not members of the plan. So some benefits they're not eligible for. You can't get ECM unless you are enrolled in a managed care plan. And also there's complexity over here in the fee-for-service world because lots of these counties have multiple plans. Sacramento County has 4. LA has at least, depending on how you count them, 4. So it can be very difficult for community-based organizations you partner with to have a contract with all of them. But understanding the managed care environment you work in as a county, who are the plans who serve the beneficiaries in your county, and how many of them are there, am I in a single plan or multi-plan situation, is super important. We could stick on this topic for a long time, but just, you got to know, are your kids in the plan or not in the plan when you start doing work around kids in care? So we're talking about 50,000 kids in general across the state. I even saw a lower number this week, down to 44,000, which is kind of an incredible number when you think about the last decade of child welfare system reform. Increasingly, your work is being focused upstream, and all of that work is relevant to the managed care plans because those adults are their members. So kids may not be in managed care today, but most likely their parents are, their caregivers are. And so this MOU is not just about the kids. Like, you want the managed care plan to pay for stuff in your prevention, in your community pathways, in your family maintenance, family unification, and differential response programs. It's a really important and new opportunity for you to bring in new revenue and expand the level of care and support you provide. So before I pass it off to Sarah to talk about the structure of the MOU and then eventually take us line by line through the document, there's tons of we have reformitis going on in California, right? Like, there's just so much happening. But I would invite you to breathe out. And when you think about your partnership with managed care, I think there's 4 areas of consideration, meaning you should have a sticky on your computer that says these 4. Meaning, if you're going to get a new check from a managed care plan, you're going to get it from one of these 4 areas. The first are what we'll call the non-clinical benefits of the managed care plans. These are enhanced care management and community supports. These generally pay a per member per month payment. They're generally associated with care coordination or the social determinants of health. The second place you might get new money is the new mental health benefits that the managed care plans administer. So until 2015, there was only one place to get mental health, county. But in 2015, to comply with the Affordable Care Act, the state added something called, at the time, called the mild to moderate benefit, something we now call the non-specialty mental health benefit, which means the health plans will provide mental health services, particularly for your parents who have court-ordered care. The plan should work with you to build a network dedicated to that function. And those new benefits are called the family therapy benefit and the dyadic benefit. The third area are the new provider types, CHWs, doulas, peers, and coaches. This is among the most exciting opportunity for you. Your parent partners could become CHWs and bill. Doulas are super important for low-income mothers and those on their parenting journey. Peers are paid for by the mental health plans, and wellness coaches are largely associated with the school program. And finally, we did this huge thing, which is we made schools automatically in network for all managed care plans. So I'm going to say this one again. We made schools automatically in network for all managed care plans, meaning that a service provided by school staff or their designated provider must be paid for. And there'll be a single third-party administrator, Carolyn, meaning if a CBO is working in a school or from a school referral, it submits all of its claims to one entity. That entity collects the revenue from the managed care plans, commercial and Medi-Cal, and returns it to the provider or school site that generated the claim. It's super groundbreaking, y'all. It's like a really big deal. And it's going to be messy. So just know, big things take time to get right. Sarah, I'm going to switch presentation so you can do the deck. You can do from here. Might also give me a chance to quickly peek the chat. Oh, great. Sorry.
I should go off mute. Okay, now can everybody see my slides and hear me? Okay. So as we think of just stepping way back, this MOU, this Memorandum of Understanding, is the first time that the managed care plans have had to execute one with the County Child Welfare Agency. The managed care plans have historically executed MOUs with many of your other county departments, but not yours. And so really this is at its like sort of highest level, an opportunity to start building that relationship. And as we've been talking with various counties, it sounds like that is happening, right? You're starting to get to know each other, you know each other's names, maybe even exchanging cell phone numbers so that you can text with your key point. And so using this as an opportunity to build that relationship, to better serve and coordinate services for your children, youth, and families across the full continuum for prevention to aftercare. And I'm going to repeat some of the things that Alex said, but really helping the managed care plans broaden their view of this MOU opportunity and what you do, from not just being about the foster youth, but being about their entire families and natural support systems, is a really important point. We have this slide in here just as a reminder of the sort of the division of behavioral health services. I'm sure this is repeat for some of you, but we in California have made things fairly complicated around how we organize behavioral health services. And so we have on the mental health side, the specialty mental health services are the responsibility of the county departments for substance use disorders and specialty mental health. And then non-specialty mental health services are the responsibility of the managed care plans. And this really is outpatient therapy, medication management with the psychiatrist or nurse practitioner, and psychological testing. ABA services, you could sort of is also their responsibility. And this, we wanted to make sure that we talked about this because in the MOU, there's language change to sort of call on them to really own this responsibility of call on them being the managed care plans for an outpatient network of therapy services for your families, children and families. Sorry, I'm struggling with to hide the Zoom controls so I can see my slides. So just some tips as you start your negotiations is start from a place of assuming positive intent on the part of the managed care plans. they do want to do the right thing. They do want to help vulnerable children and families, and, you know, have constraints within their organizations and structures similar to you do. And so I think starting from that point of everyone's coming to the table to do the right thing is important, sort of ground setting. And then also having some empathy for where they are in their journey around, they have to execute many MOUs with many departments, county departments, and small differences between 58 different counties can be challenging to operationalize on their side. And so for plans that are in multiple counties, they will be looking to standardize things as much as possible for their own operational sort of sanity, probably. And so finding that balance, right, between sort of what is really important for you and your county, that needs to be sort of unique there, versus what, you know, is okay maybe if it's not, if it's a little bit more standard to their approach. Like finding that balance, I think, is an area where in the negotiation will probably come up a lot. Saving details for the policies and procedures to make this negotiation go faster. We have a list of, with the help from the CWDA team, put together a list of all the different policies and procedures that are referenced in the MOU. And so as we've iterated on versions of this, have pushed a lot of the detail into sort of those will get developed after this MOU is signed. And it also is one reason to push the details to the policies and procedures is things will change as you learn and get experience. And it's a lot easier to update a policy and procedure than to update an MOU that has to go through, you know, your various levels of oversight and control and review and signature authorities, et cetera. And then, you know, really think through being strategic on how you want the managed care plans to use their time and effort. Like go into the discussions of like, what are the 5 things that we really, really care about? And, you know, what are you willing to give on? I mean, this is sort of like negotiation 101, but that if they could, you know, granted that they're in, what did you call it? Reformitis, Alex, like they're also experiencing reformitis and are getting pulled in many different places. And so knowing that they are stretched to doing many different things as well, like what are the key pieces that really you think will make a difference for your county and also for the children and families that you're working with. These are DHCS's goals for why the MOUs are required, to formalize the processes for how you work together and collaborate and coordinate. Describe the new role of the foster care liaison and clarify some roles and responsibilities. DHCS did also recently come out, I think it's just on Monday. I got, there's a draft all plan letter that defines the role of the foster care liaison in like 6 pages. So they're really providing a lot of detail to what this foster care liaison will do. Provide transparency into roles and responsibilities between the managed care plans and counties, establish data sharing pathways, and describe the relationship to your AB 2083 or system of care MOUs and oversight and accountability structures. So before I pull up the actual MOU and walk through some of the changes that we've suggest you might consider, we can distill them into a few points. So one is to emphasize a whole family approach and broadening the focus of the relationship to include the parents and caregivers and families in an effort to promote family stability. I think at the, 8 months ago, a lot of the focus was like, this is just about the kids in care. But if you want to leverage the managed care plans supports on your prevention continuum, or to help in your goals of reunification, including the parents as part of this and what the managed care plan can offer to help them will be really important. Also broadening the population of focus so that it's not just the youth in foster care. The language in the MOU, and we can pull this up, I think it's youth involved in the child welfare system. That's pretty broad. And so that's the language that DHCS actually put out. So making sure to remind your negotiating partners that it is, what does that mean? Like involved in the child welfare system, and helping educate them on that, where families might touch your system through the child abuse hotline system, and I refer to differential response, or they're in a sort of, an investigation, or they're in different statuses, educating them on that array of, or continuum, and then helping them see their role at different points along that. Having dedicated networks. So the idea would be that the children and families that you're working with are among the most vulnerable in the system, and having a special pathway for you to make a referral or your agencies to make a referral. That's what this is asking for. It's not just like your referrals aren't like any other referral, right? They are extra special, and there needs to be a pathway for that, recognizing that they're tied to court timelines, right? These are mandated services that families have to get sometimes. If these children don't get services, they have a much higher potential of being, having worse outcomes later. So really emphasizing why sort of what I sometimes refer to as a red carpet pathway for your children and families is warranted. The next point is around aligning enhanced care management. And so we didn't go into in depth about like what that benefit is, but I think you're getting those trainings, or you had to, if you haven't heard of enhanced care management yet, we'll send you some information, but I know there's a lot out there, but really helping the managed care plans align their networks for enhanced care management to your networks of providers, so that it's not just another random individual who might be well-intentioned but knows nothing about your child and families, who is their enhanced care management provider. Rather, that enhanced care management provider is somebody who already is known and trusted by the child or family, and that they are focusing their efforts and services and aligned with the CFT and or the CANs, right? So in this way, it's a supplement of revenue and support for an existing service provider to help them better execute against the goals that are central to that child and family. Not just another provider who might be doing telephonic service from some county, far away, and doesn't know the ins and outs of your community and that child and that family. We already talked about this, putting policies and procedures in the MOU. The next item is around the AB 2083 alignment. How do you want them to be involved, right? Do you want the managed care plan at each of your local leadership committee meetings? Do you want them to be active participant? Like really defining, you need to decide before you go into these meetings what you want and how you want their involvement, and then put that into the writing. What we have heard from most counties is that they do want them at the table in these leadership meetings, at the AB 2083 meetings. But that might not be the same for every county, but decide and then put it into the MOU what your preference is. The next item is around a population health management program for foster youth. So there's an opportunity to really collaborate with the managed care plan on looking at the total outcomes for foster youth. This is a group of this is a group of members who are very easy for them to identify. They have an aid code, and they already report quality metrics for children to DHCS on various, I think on a quarterly basis. And actually, DHCS is finding and sanctioning them for the first time for not achieving certain metrics. And you can look all that up on the DHCS website if you want to see how your plans are doing. But that they have to report these quality metrics for children and youth already. Your population is very easily to be identified by aid code. And so create some population health programs and goals related to the data for this population. And you have an opportunity to participate in that creation, or at least the review and sort of continuous quality improvement around those goals. And then the last item is around data exchanges and really creating permissible structures to create registries of particularly medically complex or certain groups that do need more close watch, and then monitoring them jointly, and then identifying populations for dashboards to sort of go back to that population health approach that you're looking to see, how are all kids doing on having their well child visits? How are they doing on getting their vaccinations? How are they doing on having a primary care provider and going to the pediatrician, lead screening, these things that are important preventive measures, working collaboratively with them on them. And the managed care plans are strongly incented to improve those metrics. Back to my point around DHCS is issuing sanctions related to not achieving metrics in those child prevention areas. So now I can pull up the MOU and we can go through it. Just really quick sort of context to it. There's 3 colors of text in the MOU. What we did was we took the state boilerplate MOU, made it a Word document, and then went through it, and there were places where DHCS offered optional language. We incorporated much of that optional language as green text. The blue text was brand new language that the Public Works Alliance team, in collaboration with some counties, have added to sort of go above and beyond what the boilerplate MOU said. We have confirmed verbally with DHCS that that's fine to go above and beyond, right? They might review it still, but you're not permitted to ask for more. You might not always get it, but you're permitted to ask for more. And so our position was sort of, well, let's ask for what things that you think could be really important and valuable, and then have a negotiation with the managed care plan. And then the red in places is language that just maybe didn't make sense and could be scratched. It might not impact your operations and it may not be worth touching, but it's important the managed care plans are not the provider of medical services to the foster youth, right? They're the organizers of the network. And so they won't necessarily have up-to-date daily information on what happened at a provider setting. They have claims information that is probably ideally 30 days old only. Sometimes it's 60 days old. And so so a lot of the kind of context of some of the red language is assuming that they're more of a provider than the organizer of the network. And so suggesting that maybe it's an unrealistic expectation that they're going to have some of the information that the boilerplate had in it. But again, probably not a deal breaker for you if you leave it in or take it out, because it's about their obligation. And then just really importantly, that all of this is a starting point for communication and alignment on better system goals. If as the outcome of this, you feel like you have a better relationship and are aligned toward working together proactively and collaboratively on improving outcomes for your children and youth, that's success. So maybe you don't get every language aspect that you need or that you want, or that we've sort of recommended, but that might be okay. And we've heard some feedback from managed care plans. So I think most of the managed care plans have seen a version of this that I'm going to show you. And they've taken it back under consideration. And I think, but we haven't yet gotten a response in writing. So I think they're,
Mhm.
I think they're trying to find the line of like, what can they do to sort of acknowledge the asks within their sort of operational constraints and where they're at. So I may not be very clear, but I think that's kind of where things are at this point. So if you brought this MOU to them, I'm guessing most of them would say I've seen it already. Maybe not all the local plans, but certainly the multi-plan county, like I know Anthem, HealthNet, Molina, Kaiser, LA Care, Blue Shield. I know they've all seen it.
Yeah.
Okay, so I'm gonna stop sharing now.
And so maybe just for a pause, just to repeat to everybody here, you are literally free to cut and paste this thing and do what you will with it. Like, if anybody tells you they know how this is working, they're selling you something. Like this connection between child serving systems like foster care and probation and managed care is new. So you're groundbreaking. And that's why our suggestion is pick the things you think are most important to you, real specifically, and work from there. But there is no like right way here. And what I can just say from a couple of the negotiations, we went to San Diego and got punched in the face. They were like, no way, this is too much. We had some conversations with HealthNet, which was like, oh my God, this is amazing. We can't wait to help you. Like, and everything in between. So, I mean, I just want to like, this isn't like a traditional negotiation with a provider or another county agency. Like, it's just different. So I think our strong recommendation is to ask for a lot.
All right. You can see the Word document. Okay. So again, at the top, just is this explainer on the different color text and what it is. And this first comment here, this is mostly relevant to Los Angeles, where Los Angeles has 2 main plans, but they both have subcontracted, fully delegated plans. So in LA Care has Anthem Blue Cross and Blue Shield Promise as its delegated plan partners. And then HealthNet and Molina are plan partners. And then there's Kaiser. So this, you will, in LA, I don't know if anyone's from LA, but will only execute the MOU actually at like the LA Care level. They won't execute the MOU in LA with the subcontracted delegated partner. So that's what this is referencing. And then, so suggested term, 3-year term for the MOU, because I'm guessing you probably won't want to go back and do this again in 18 months. And another reason why putting details into the policies and procedures is useful. The Child Health and Disability Prevention Program has been sunsetted. And so this is really just a reminder to the managed care plan that it has those obligations. This is probably where we've gotten the most pushback around this request that the managed care plan make a good faith effort to align its enhanced care management and CHW network with the county's network for child welfare services, so that members can receive services from a provider with whom they have already have a trusted relationship. The county will provide the managed care plan a list of those providers. And then that you will work collaboratively to develop policies and procedures to deploy presumptive eligibility or create a streamlined enrollment process for ECM for any child meeting the population of focus definition. So on the first point, I don't think you should give up on this one. It is effort to contract with another provider. And then there are many of your providers there are some of your providers who might not have an easy time contracting with the managed care plans and meeting all of those, all of their requirements. And so there's either community hubs that are out there or maybe a glide path with the managed care plan to do this. Many of the managed care plans are investing a lot in in developing and supporting community-based organizations in becoming contractors. And so increasingly, hopefully there are paths to allow this greater alignment to occur. Then the DHCS had a meeting, its child task force, a meeting on Monday, where it is also sort of aligning around this idea of presumptive eligibility and making it easier to get authorized for referrals. And so I think you have a lot of policy support right now going for this request. This is another reference to policies and procedures to work collaboratively to develop oversight reports and mechanisms to address barriers to care or to barriers to care coordination. So basic, you'll write out in detail, like how their foster care liaison is supposed to work closely with your point of contact, and then ways to, continuously oversee that and improve it. This green language was adoption from DHCS's suggested language to include the managed care plans in your system of care meetings, and that you're basically saying that they shall participate, right? So they are not legislatively required to be a participant in the SOC meetings, but if they sign this with you, they are contractually obligating themselves to participate in the SOC meetings. Continuing to go on, the next section is around your county obligations. So this green language is the adoption of DHCS suggested language, not new language that we wrote, but that you would work to develop and implement compliance policies and procedures. You will allocate, you being the county would identify a point of contact to ensure that there's training and education that is laid out in the MOU occurs, and that you would educate members or caregivers about their covered services under EPSDT, which is now the Medi-Cal Kids and Teen Services program, for which they're eligible, and refer those children based on screening findings to the appropriate services. There was some, now it's in the training and education section. So there's a lot of, the plan will educate their members on this and providers on this, that you'll do education as well. So this is getting into sort of how you collaborate around training and education, and suggesting here that within 45 days of executing the MOU, the managed care plans will offer trainings to their, is this network? Or downstream subcontractors about what's required here. And again, more that you will work together to develop training and education resources for the providers. The next section is around referral processes. This closed loop referral language is not new language that we've came up with. This was optional by the state, and saying that by 2025 or within 90 days of issuance of guidance by DHCS, that you will work to develop a closed loop referral process. This can be either a technology platform, like in some counties, Unite Us or Find Help are examples, or it could be a process around using secure email to email and respond. And so I think you can make this as complicated as you want, or you can start off making it just, we will acknowledge receipt and what happened to a referral within a certain amount of time, or creating a spreadsheet that has the disposition, right? And they send it back to you. So I think rather than wait for like the world's most amazing technology solution to appear and to solve all of your coordination problems, maybe start kind of basic around, is there a spreadsheet that we can share and communicate back and forth via like a, secure email or something, and then work toward the bigger, fancier solution, but don't wait for the big fancy solution to get started on figuring out how to close, if that makes sense.
So if I could just jump in quick on this one, just because you guys are all involved in various forms in this, like there's basically 3 big players in the managed care world for closed loop referrals: Unite Us, Find Help, and 1Degree. Are you with me? Hope that sounds familiar. And this is part of this broad world of trying to address social needs. And this requirement that managed care plans have a closed loop referral system is really important for you to track, because I know a number of child welfare agencies are also very interested in this topic. So how you align or not, right? That's a strategic question, but you could probably see the advantages of using a system together.
Oops. I'm gonna go, I just pulled up the chat while Alex was talking, so I'm gonna go back and address this question about medical necessity in section 4.
Yeah, I took a shot at it.
Okay.
Yeah, but for everybody, it's a great question, because I know that term activates probably people in child welfare. Historically, when you refer to kids to specialty mental health and they're like, they're not sick enough, they don't meet medical necessity, right? That's no longer a thing. So in the chat, I put the National Center for Youth Law and the National Health Employment Law Project's analysis of the 1915B waiver. That's the waiver that governs county mental health. And if you look at criteria 1, it says all children with child welfare system involvement presumptively qualify for specialty mental health. Super important, you guys. Like, so your county mental health plan isn't allowed to say no. They can say we need to do an assessment to figure out what level of care, but not no level of care. And then the other thing I put in the chat was a description of something called the family therapy benefit, which was the first Medicaid benefit in the history of the nation that qualified you for access to mental health based on an experience of discrimination, food insecurity, or adverse child experience. So to answer that question directly, and then Sarah, please fill in, all services in Medicaid have to be medically necessary.
Mm-hmm.
So that's just a thing. But the definition of medical necessity has been fundamentally reformed in California over the last 2 years to reflect ACE's science and the social determinants of health. So it's kind of good news.
The only thing I would add to that is it's not just it is not a locally defined decision. So the interpretation of medical necessity is maybe at the plan level, and then there are paths to appeal and file a grievance, right, of any decision, but the actual definitions of medical necessity are set at the state level and not the local level. Why the term 3 years? I mean, so Jessica, I mean, it could be a shorter term. I think some of the feedback we got from some counties was that 3 years, it's an initial term of 3 years. It doesn't mean that you couldn't, there's a couple triggers, I think, to review it And like if there were new guidance or new something that came out, you could review it and you could amend it, right? Like there's an amendment process if you needed to, but just setting the initial term at 3 years with the knowledge that you might amend it and that certainly your policies and procedures might change as you learn and implement. Diana, did you add anything to that? I saw you shaking your head.
No, that's right. Vicki, we worked with you on the language when we get to that section around the review, the regular review of the MOU, to give county child welfare agencies some ability to say, hey, like we actually want to revisit some stuff. This isn't just automatically going forward year after year. So you have some options there.
Mhm.
And Jessica, you're a partnership county. So they have 26 counties to do this with. And Mark Bontrager, the guy leading the work, is amazing. He's a good dude. So like wants to do the right thing. There's no, like, it's not gonna be drama, but I think, yeah, it's a lot for them. Again, I don't want to sound like I'm too empathetic to the plants, okay? Like, we don't have to, they have a job, they're getting paid. But I think you might not get the biggest and best response if you're going back to them every 12 months.
No, go on. No.
All right. Okay, so this next section in blue is new language that went above and beyond the requirements that were originally put forth. And we do say the details of this would be put in the policies and procedures, but didn't want to punt all of it to the policies and procedures because then, you know, those don't carry contractual obligation, right? The MOU does. And so one item here is around dedicated referral pathways, that the managed care plan will create a dedicated referral pathway for children and family members involved in child welfare. And like, again, the broader definition here, right? Involved, not like in like have a foster care aid code for non-specialty mental health services, enhanced care management, community supports, and community health worker services. Managed care plan will create a HIPAA compliant online pathway for electronic submission of referrals and will provide updates via the online system, secure email, or another agreed upon format. This second sentence here gets a little bit back to that closed loop referral system. And so maybe you could scratch this sentence and say it's already covered in the closed loop referral system, or say, you know, the closed loop referral system is really about referring to, you know, all the communities, and we don't think we're going to get the detail that we want on these specific referrals. And so we want to be able to have, and this is very similar to what they have on the behavioral health side, right? So when they do referrals back and forth, they being the managed care plans, refer back and forth with their behavioral health county partners, and are supposed to close the loop on those referrals. And so they should have some process for something like this with behavioral health. And then non-specialty mental health referrals. So the managed care plan will identify specific providers within its non-specialty mental health network that will accept referrals for children and parents and ensure timely access standards are met for appointments within 15 business days for psychiatry and 10 business days for therapy. So this is just calling out an existing obligation that they have in their contracts with DHCS, but saying that they will identify sort of a subset of providers in their network who will take referrals from the county child welfare department and serve them. And the reason why this is important is that a lot of the networks, a lot of the providers in the managed care plan networks are private individual therapists who are not part of big organizations, who may not historically have worked with families and the level of complexity that your families are dealing with. And so that might require a sort of a curated group of providers that they refer to, right? So referring, somebody who's 90% of the people they see are commercially insured individuals dealing with existential crises over like, what college do I go to? Like, I'm being a little bit hyperbolic here, right? Versus, and then they get a referral for somebody who's in a really complex situation that might not be a great fit. And so finding if they have a smaller list of providers who know that they're going to get these types of referrals, treat them differently, and then maybe even get some extra reimbursement for some of the sort of, communication or maybe a report writing that might be necessary. So Gold Coast Health Plan is an example of a health plan who negotiated and did this with Ventura County, where they went out with their managed care, their behavioral health partner. They identified a set of providers who were willing to take parents referred in family reunification for therapy, and then paid them a little bit more on a care coordination code that had to be approved, but to communicate back with the social worker, right? Knowing that that was not billable time under sort of the traditional therapy code, like you can bill 15 minutes if you have to talk to the social worker and give them an update. So there is a best case, sort of a best practice example in California that Ventura County developed with Gold Coast Health Plan as plan partner. And that was the inspiration for putting this in here. So it wasn't some, idea that was dreamt up without any precedent. And then referral reporting. So at the quarterly meetings between the managed care plans and the counties, reviewing the status of referrals submitted and identifying, how long is it taking? What are the barriers to care? Are there ways that we can work together to improve this? All right, I'm gonna go a little bit faster because I'm tired of hearing myself talk. So on the care coordination pieces, again, sort of just adding that you may opt to align it with your system of care meetings, so that you're not creating new meeting structures or separate meetings, that your policies and procedures must include processes for coordinating to ensure members, and just calling out here that it's children, transition age youth, parents, and caregivers, right? Being explicit that this is not just about the youth, the foster youth, receive ECM, CCM, behavioral health, and community supports. And that may help, they may qualify and address their social drivers of health, determinants of health. The next section here is incorporating DHCS language around local interagency leadership teams. This line here is, what this means is the managed care plans have to make sure that the children who are enrolled in their plan, they're held to a quality metric of, did the child attend the well child visits at the recommended ratios or frequencies as the American Academy of Pediatrics. And so again, they have this obligation, and they're saying that you must coordinate with them on that. And so what we're saying later in the reports or the data sharing is that they need to tell you, right? Like, how are they doing for your population? So the data section and exchange section really is reinforcing this requirement that DHCS suggested to include. I'm going to keep going. So more around coordination for the Medi-Cal Kids and Teens Services program, so that you would, what we had some initial language here that I think that was more prescriptive around, like, they'll get the cans and they'll incorporate the cans into it. And we dialed that back a little bit to say that the managed care plan, they would confer with the county on any existing or needed assessments and jointly determine the appropriate pathway for obtaining information and follow the member physicians or licensed behavioral health providers. So sort of recognizing that there are assessments that are done in your system, and that those should be taken into consideration. This is suggested language that probably isn't necessary and probably not attainable. And so the note here is like, just discuss with the managed care plan and see if you really need to keep it in here. Again, calling out families and caregivers, conferring around assessments. This item here does call out the CANS assessment. So this obligation we deleted because this was that, got to think about why.
On that one, I recall it was because it really did, the plans don't really, we know before the plans do, and this is
Right.
an obligation, so we were okay getting rid of that, and we told the state that, and they seemed to be okay with that.
Thanks, Diana.
And that was at the plan's request, yeah.
Mhm. So informing all members of transportation resources. So just really calling out transportation here is because that's a particular barrier that comes up frequently, and that non-emergency medical transportation is a Medi-Cal benefit available through their managed care plan. Again, just really being explicit, calling out substance use disorders and adding parents and caregivers. A little bit more detail around coordination for court referred services. Another reference to the AB 2083 local interagency leadership team.
That's one I really want to, like, we need almost Diana and Belgique. There's like a whole world of learning there. Like the original template said, join every CFT, and everyone was like, what? So that's gone. But there's obviously a role for the managed care plan on the 2083. But I think the actual structure, because people are doing it. Ventura's already doing it. Other folks have made really good progress. And it would be fun to like just find out where it's already happening and learn what's good about the or not, you know? Because what I have, 2083 goes back to the children's system of care days. And there can be a lot of collaboration around collaboration that doesn't act like, I'm super curious, how is a plan sitting on that 2083 meeting actually led to more and better? Yeah, I'll leave it at that. But
So, and if you don't mind, I think we should, we'll have time at the end of Sarah's walking through this with us to talk maybe a bit about that as well and touch upon it. There's different ways to do it, clearly. There's different reasons to do it in different ways. But if you think about it, in this, I will say CWD did recommend that there was reference to 2083 crossover in the MOU when DHCS was drafting their MOU. Like this is before it was released. And the reason is very much in line with what Alex and Sarah are sharing, is that it is so important to, from a systems point of view, at a systems level, determine how are our different agencies working together, leveraging as much of our scarce resources together as possible and coordinating on this. And from that systems level, that's really where your directors that are part of the 2083 teams can be working with your managed care plans to go, let's think about how we invest together. Because individually it's never enough, but together we can really go a long way in meeting those needs. That's not to say that there may not be issues that come up through the CFTs where that may warrant some support from your managed care plans. And that is where you will want to lean into your liaisons in your county with your child welfare. What's now called foster care liaisons is going to be called child welfare liaisons at the managed care plan level to work through some of those issues on a child by child basis. And it is very possible that you may have a managed care plan in a CFT, but it would have been a big staffing challenge for the MCPs to get them to every CFT. So we were very cognizant of that not wanting to think about how we all kind of invest our resources properly and as best as efficiently as we can to really do get the best outcomes for our kids and families. So that's the approach that was taken with those changes.
Great. All right, the next section is around quality improvement, and then we get to data sharing, and so we're almost done. The key adds here to the quality improvement section is around this request for dashboards, and this is repeated in the information sharing section, that to do quality improvement, you need to have some measurement, right? And so this idea that you can agree on some dashboards with the managed care plan, and we suggest here sort of 3 groupings of those dashboards. One would be referrals. So what's the status of the referrals for children back and forth? What is service utilization? This shouldn't, like, the referral one might be a little bit more manual work. The service utilization one is not that hard. It's it's doing a claims report against the sort of aid codes that are already identified. But how many, do they have a primary care provider? How often are they going? Have they been going to the emergency room? Have they been in the hospital? Right? There might be things, and like looking at those rates. And the idea with the dashboard is that it's population level, but you can drill down if you want to. And then health outcomes. So again, I already made this point, but there are certain measures that the plans are already, and they're called HEDIS metrics. So HEDIS metrics are these standardized measures that all of the managed care plans have to report and they invest a lot in achieving good HEDIS metrics. So reporting the HEDIS metrics for the children that overlap with your system. Some gets into data sharing and confidentiality. It is not my depth area of expertise. So the language here is left from what DHCS suggested. This is around trying to make sure that they have an understanding of the expediency with which sometimes you need information related to investigations.
Sorry, Jackie's asking one of this question we've been struggling with in some other counties too. How to determine, like, if a kid's in family maintenance, we don't think they have any identifying member code. Sarah?
Yeah, I can pull up. So I submitted a request to DHCS. I can pull up the list of aid codes, and so I don't like. There's the kids. I don't know what you mean by like not an out of home placement. So there's the adoption aid codes and kinship aid codes, which are a whole set. Then there's the kids in an active out of home placement, of which I think 44,000 right now. And then there's the I'm not going to use the right terminology, but the family maintenance, they're not removed, right?
Yeah, so what I'm talking about is what Alex said, which is either court FM, court or voluntary FR, VFR, VFM, or even cases where we might be able to keep them out of child welfare altogether, and they have a differential response pathway that they're being served through, right? Those kids are going to show up with their underlying aid code. So when you create a dashboard that is for child welfare involved children, it's a little bit different than children in child welfare, right?
Yep.
So that's why I was bringing it up in terms of expanding the population. But how do we get those metrics to be able to track the same metrics for the out-of-home placement that we do for the children who are in the community? That way we're comparing apples to apples when it comes to outcomes you know, and the services being provided by the MCPs.
I addressed the first part of your question with this comment, but not the second part.
Yeah.
So my idea around, or our idea around the first part was that the only way that they will know is if you tell them, right? And so you have to provide a list of the children, youth, or parents that go beyond the foster care aid codes available to the managed care plans. So that's the only way that could happen. But to your second point around, if each county does that differently, then you're not
Yeah.
comparing apples to apples. And so there could be, as like sort of a second iteration of this work around these dashboards, there could be sort of a shared learning community for creating these dashboards around what to include and what not to include in the definition, so that there is standardization of definitions. That work just hasn't been done yet. Does that make sense?
Yeah, I just think that providing a list of children who are outside of the out-of-home placement population, there may be limitations in terms of our ability to provide that information, because we don't know. That would require for DFCS to have knowledge of which plan a child welfare family has that does not have an open case. And I don't know that we can require our families to give us that information, because they're not actually court ordered to do so, right? So there's all these complexities that happen when we expand the target population. I think measuring metrics for the population that has foster care related aid codes is a little simpler than our prevention population that does not have these aid codes.
Way simpler from a
Yeah.
like
Yeah.
technical standpoint.
Yeah, but I think in the intent of this, though, is to be able to serve families outside of foster care.
Ideally, to prevent them from entering.
Exactly.
To strengthen them and support them together. Yes, I think that is
Yeah.
an excellent point, Jackie. Let us take that back, because we do really need to think about how we approach that. And I agree, it probably should be something that we do from a statewide basis, somewhat,
Yeah.
consistently and uniformly, especially because, well, when they're with their families, maybe they won't move so much, hopefully, but there is that prospect of when they're returning home, there is that movement. So
Yeah.
let us get back to, let us make that a to-do after this.
So since I'm on the data elements, maybe I'll finish the section, then we'll go back. But the original data elements that DHCS had listed here was very clinical. And in some feedback we got from some medical directors of child welfare departments was that there may be cases when you need the clinical level information, but by and large, he couldn't think of like what your social workers would do with this clinical information, for example, or like what and so the suggestion here was to pull it up to the sort of population level with these dashboards. You may at your county have a different use case and really want this clinical level information. But the other thing is that some of this information is going to be at the provider level, right? Like the managed care plan doesn't have progress notes and assessments at in its claim system. They would have the demographics, they would have diagnoses, they would have prescriptions that they've paid for, labs that they've paid for, and services that they've paid for, but they don't have progress notes or clinical information. So the idea here was to suggest using dashboards, and then also recognizing that this would take time. So I think, Jackie, to your point, this sort of like it would, within the first year of executing this MOU, would collaborate on sharing information and defining what that information is. An acknowledgement to your point that they won't know the people beyond their aid codes, right, and who that is. So you need to figure out definitions of that group. And then this idea of creating registries to track outcomes for foster children and youth with certain chronic medical conditions, such as diabetes, asthma, sickle cell, genetic anomalies, trisomy 21, etc. But there are a particular group of, frail and children that need extra attention. And so specifically looking, and a registry is just a list, right, that you look at and track over time, and to make sure that they're getting what they need. That they would share on an as needed basis any medical information on an individualized basis, such as diagnoses, medications, and utilization. And that they would share de-identified data via dashboards on a quarterly basis, and in these sort of dashboard groupings that we already reviewed. So I'm going to go back. There's just like 2 more pages, I think, around the timing.
And it's really hard to see how people are feeling through Zoom. So I just want to say,
If anyone's listening.
Well, while you're scrolling back, I would just say the data that you just discussed, I mean, that is the sort of data that we're lacking in our child welfare, child and family services outcomes and accountability system, right? That like well-being piece. And what if what we're doing is making a difference in the well-being and of kids, and if it's making a difference for their safety, permanency, and well-being. And so think of it as sort of an additive to sort of that overall picture of how are we serving kids and families, and is that service making a difference, and is it a positive difference? So there's just a lot of nice overlap, I think, with your CFSR process.
and remember, everybody, the reason we did some of the slides in the beginning was that all of this is in service of just a couple essential elements. So like, we should maybe revisit that at the end, so like you can see how this all fits together.
Yeah, so this is actually the last change. So this is around amendments, and just to the point around 3 years, and maybe that's too long. This idea that it shall be reviewed annually and as necessary, right? Based on issuance of new guidance by the state to determine if any changes need to be made, and then for amended. So it's not that you should review it annually, but it needs to be renewed for sure within 3 years if you haven't already amended it. And so I can go back really quickly to sort of those distillation points and then just have some discussion. Right, so this is the Cliff Notes version for anybody who nodded off. The key points around the MOU negotiation, it's a whole family approach. So broaden the focus of it to be on include the parents, caregivers, and families to promote overall family stability. Broaden the population of focus so that it's not just those youth actively in foster care, but child welfare involved or at risk. Ask the plans to help build dedicated networks for the children and families in your systems, and align around enhanced care management so that the enhanced care management benefit is reinforcing and advancing the goals that are critically important related to the CFT and the strengths and needs of that child and family. Those are the 4 like overarching themes to try to get through the MOU negotiation. So with that, I'll open it up for discussion.
Oh, let me unmute there. There was a question in the chat, I don't know if you caught it, and it relates to probation youth. What is the opportunity there, do you think?
So I asked, that's a great question. Is it Anna? Yeah. When you look on the state's website, they suggest that justice agencies will be executing their own MOU. But like in the county I lived in, like half of all kids in detention were like 241s. I don't know if everybody else, I'm very much an Alameda County homer. So like it would seem to me that there's lots of opportunity for overlap here, potentially doing them together. But remember, juvenile and adult probation are really different. And there's a whole huge adult justice, DHCS justice service serving initiative that has like in reach to jails, and your sheriffs are getting money. So my sense is they're going to be separate. That's my quick sense. Even though many of us don't like that separation of the juvenile justice kids and the child welfare kids.
I can add some additional information to that because it's something that I've brought up ever since I first saw the MOU last year, that probation foster youth were not captured in this. And DHCS, when Diana and I met with them and talked about probation foster youth, they said that you could essentially do this either by asking your probation department, your juvenile probation department, to come join you in this child welfare MOU with the managed care plans and really make sure it captures the probation foster youth, or they could essentially maybe create one separate. Like Alex just mentioned, there is the Justice Involved initiative that is a big initiative inside of CalAIM, and it does look at adults and children. But there's an eligibility criteria that eliminates some of our probation foster youth. And that criteria is that they had to have been incarcerated in the last year. And what we know about probation foster youth is some of them have been in placement and don't actually step back into a juvenile hall facility in that year. And so DHCS again said that you could either bring them into this MOU, or the probation department could execute a separate MOU to capture their foster youth.
And of course, we know that probation foster kids can be placed in, for example, STRTPs and family-based settings. So what we've discussed earlier around the 2083, I mean, that may be where you start, with the probation inclusion as well. If you have your managed care plans in the conversations with you, with probation and others, there's that opportunity, regardless of whether or not they're formally in the MOU agreement with the managed care under your child welfare MOU. So you have a few different ways to kind of get at this. I will say too that we are always working with CPOC staff. They're fantastic. I don't know that I know that they viewed it from the justice lens much more so the child welfare lens. So I think they're kind of not there yet, but very interested. And we continue to talk and work with them on that. Let's see, Amy, I saw your hand go up and you took it down. I'm gonna call on you still.
I think you mostly addressed it. I was just curious if that expansive definition applied for like their diversion, like where they're touching the system, but they're not in foster care. That's so.
Yeah, I know that there's work groups happening at the local level. I mean, the oversight and monitoring of the Justice Involved initiative is pretty heavy from DHCS. And so, hopefully probation is lifting up. We have youth that don't enter juvenile hall. And so making sure that they capture all youth, and maybe there'll be a population, they'll fit the criteria under one of the other populations of focus. So yeah, there are opportunities, but I think it's really going to be important for probation to lift up the youth and how they work with this population on their side.
So now that you've seen the kitchen sink MOU, the famous kitchen sink that we've been waiting for a couple months now. And we know that there have been some counties that have engaged in the process of, with Alex and his team's help of talking with their managed care plans. I kind of want to open it up to folks, and we purposely meant have structured this webinar to be more open to folks to raise their hands and talk and be a little bit interactive. What are the things that you see as some great opportunities for you all in child welfare? Are there any worries or concerns you have? Or things that you feel like you would like a little bit more support or assistance in, that potentially we can all kind of get together and see how we can assist you. What you're
Diane,
thinking. Yes, go ahead, Veronica, from NASA.
Hi, how are you? I was wondering what was the next step that was identified in terms of looking at services to the voluntary FM type cases or referrals when they don't have an A code? Is there was there a next step outlined for those?
I think we're going to go back and have a conversation around how do we create some statewide consistency in some sort of a data sharing or tracking mechanism for that. I don't know if it's going to be, and I don't know that aid codes take a long time to stand up. It may not be an aid code, it may be something else. I'm also thinking about the fact that we are going to be standing up FFPSA prevention, right? Or you are all working on that. And there's going to be a need to do child-specific tracking of funding, right? And money spent. There's also the pay or less resort, and we're not allowed to sort of tap in, to those, we have to tap in those federal resources on the Medicaid side before we can tap into the other funding sources. So there might be some opportunities, especially as we're lifting up CARES, to think about how we might approach that. So I want to kind of get some folks together and think through how we might do that. So I don't have a concrete next step other than we're taking it down and noting that we're going to have to probably do some follow-up work on that for you all.
Thanks, Diana.
Just as a specific example, Veronica, like literally this morning, we were talking to San Francisco, and they're very interested in the FM cases that aren't in their treatment court because there's such a wide disparity about those families in the treatment court are getting a lot, and the FM cases who aren't in the court aren't getting much. And we were trying to get our brains around, well, who got screened by specialty mental health? Like, and we realized it's like not good information. Like there's really no way to get it. So the only way to get it would be to do a flat file data transfer with the plan with identifying information. Like it's a data exchange question, but per the conversation around Santa Clara, it depends on what county you're in and how many plans there are. So the idea basically is this MOU would create the infrastructure for such an exchange like that to happen. Would be the best I could give you.
Another next step, since we're on it, is we might, we're talking about maybe bringing counties together with the managed care plans that they have in common. So for example, like a number of counties have Kaiser. So perhaps we bring together the Kaiser counties and maybe also have a conversation with Kaiser together. Having given them some time to reflect on the MOU and have that conversation around what are our visions and goals together for serving kids and families, and how does the MOU serve as a pathway or a vehicle to support that. So we're talking about doing that as well. So more to come on that as we figure out the logistics and timing of that.
Yeah. So you guys, I've been joking on Zooms that my kids tell me less of me is required. So I just want to say, but I was just thinking this is what I would do. So take it or leave it, y'all. This is it's easy to sit on a Zoom screen and say you should, right? But you all live in safety net systems and you know who the providers are who are doing good work. Like every one of you here has someone who you trust and believe in terms of serving your most vulnerable children. That entity is unlikely to be contracted to manage care. Because to the degree you already have a relationship with them, they've been getting their Medi-Cal from county mental health. Are you with me? Historically, the only game in town was county mental health. So one way I might approach this challenge is literally think of the people who are my most cherished partners, who I wish could do more for me if I had the resources, and walk the road with them to manage care, plan partnership, and reimbursement. Easier said than done. And I put in the
Certainly a journey. Oh.
Yeah, and I put in the chat, sorry, a little bit of a recommendation there too. Particularly for smaller orgs, under 5 mil. Holding a contract with a managed care plan and developing its own claim submission process may not be possible. Like juice versus the squeeze conversation. So there is an emerging world of players who are helping aggregate community-based organizations to be in relationship with the managed care plans. And a couple of them are really good and interesting. And I would definitely direct you and your providers to the Full Circle Health Network, which is doing this at scale. There's some examples in Southern California, like neighborhood networks. And these are entities that are trying to spread the administrative burden and get contractual status with managed care plans so a distributed network can play in these reimbursement opportunities. So learning about them and helping your trusted partners access them might be another thing to think about.
Yeah, I mean, maybe to put a finer point in that, I think, Alex, you've done a really good job of highlighting the fact that these outside of the state network providers are coming in and they're $10+ million contracts, and they can afford to take the lower cost per member of ECM and community supports. And so completely shutting out your local community-based providers that you might prefer working with, right? Like that is the concern. And so we don't know that we can convince a managed care plan to pay more for ECM and community service. Like that, that clearly is a hurdle that, we could try to tackle, but, they're going to be reluctant. And so what are some of those other opportunities? And maybe that's a next step. We did have Full Circle Network. Camilla Schrader came to the January webinar. But I know our time was kind of limited and we went through really fast. And so maybe those two networks, Alex, are ones that we can bring to a future conversation here, because it is like what, and the other thing is it's not just them, right? So you have public health departments locally also required to enter into MOUs, and also already billing to Medi-Cal. You already have your county behavioral systems as well. Like, again, we know that the benefit per member per month or however it's paid out is not a whole lot of money. But again, it may be just one of those, working with, as Alex said, your preferred providers, your trusted entities. Certainly we hope within your county, public health and behavioral health are on that list, but you probably have some others. And how do we ensure that that is part of your preferred provider? Because there is, and Sarah referenced this, we had a meeting on Monday with DHCS. We're talking about ECM and community supports for kids, youth, and families. And the department acknowledges that this is a benefit that was essentially evolved from whole person care from an adult population. And we are still very much in the early stages of building out the supports and services for kids and families and the very specialized populations of the kids and families that you all serve. So I think that, and thanks for dropping that in the chat, Alex, appreciate it. So definitely look at those two websites. The Full Circle Network is a group that spun off of the California Alliance of Child and Family Services, which represents a lot of your FFAs and STRTPs, and even some family resource centers. And I'm not actually as familiar with the neighborhood network, so looking forward to learning more about them.
There's sharks in the water, you guys. So there's a lot of people who are trying to play this space. So just, walk clear-eyed, give some of us a call who don't take any money from none of them. As you take a look at these actors, Haluna Health is out there, Hair, whatever it is out there. There are private entities who are stepping into this space. So just, tread carefully.
And I think it's just important, again, and this is the relationship building and conversation, for you all to make sure your managed care plan know that if there are entities that they say they're bringing on board that are from out of state, that don't work with your foster kids in your communities, you should make that known to them, that it's not going to be good enough for your kids and your families. All right, you're a quiet group, so we want to hear more from you all. I do call on people sometimes just for fun. Danny knows this well.
Diane, I got one more just in the silence. Yeah. Look, we can all reasonably believe that every single one of those 44,000 kids in out-of-home care should be getting something from Medicaid, right? Like if you can't stay with your birth family, something's happened in your life where you should receive social and emotional support. And there appears to be some pretty significant movement on the CDSS side with the rate reform proposal to help make that happen for the higher need kids. you know, if STRTP step down, potentially new immediate needs funding. But there's a role for managed care plans too. So if you think about those 40, let's call them 45,000 kids in a pyramid, and you think 5% are stepping down from STRTP and need super wrap, 10 to 15 grand a month. And then another 20% need wrap. Let's think 6 to 10 grand a month. And I'll put this, our paper we wrote on this in the chat. You still got a group of young people for whom maybe what they need is a flex fund and a CHW and access to a therapist when they need it. So as you think about an entire population of kids, there's going to be a role for the managed care plans, or for, in some case, fee for service Medi-Cal. Because if they can't get ECM, they can get CHW. That's a fee for service benefit. They can all get non-specialty mental health. So there's going to be a role for these benefits as we seek to ensure that all kids who can't stay with their birth families get some level of support.
Well, I just want to add that in the continuum of care management, the DHCS has created under this. ECM is the highest tier level of service, and then you have complex care management, and then you have basic population health management. And this is under that medical covered services that was kind of called out in the MOU. It's important for us to know what the slew of services are expected to be provided by the managed care plan, because if they feel that a youth, a child, a family doesn't qualify for service A, they have a slew of services that they still may need or maybe qualify for. And so it's really critical that our staff really know what those slew of services are, and that ECM is seen as the highest level, but they also have all these other services as well. And so it's going to be really critical that we train our staff on that as well.
Do counties feel like you need additional training in, for example, those slew of services that Baljeet is referencing and what came up earlier? I mean, these are the broader EPSDT services. Because that's also something that we could talk about as a next step coming out of this, is how do we support getting you all information that you need or for your staff to be able to look for those right services and be able to ask those questions of your managed care plans.
And some of this is going to be covered in the training that we've been doing with CFPIC. CalAIM 201 is going to go through ECM, community supports, the non-specialty mental health services that Alex was talking about earlier. And then we're going to cover some other things that are under those covered services. But the staff that we're seeing come to those trainings so far are folks in leadership. And so it's going to be really critical. How do we continue to move this information down to the frontline staff, the frontline supervisors as well? And I'll put the flyer for those trainings. I think we have one more on CalAIM 101 coming up, and then May and June is really dedicated to 201. We also have TA office hours where you can come and talk with myself, and then Gretchen Schroeder. She's here, I believe, still on the call. She's been leading those trainings for us. And so it's an opportunity for you to really engage with us one-on-one and talk to us about your needs in your county. So I'll put the flyer in the chat.
Additional questions, comments, thoughts?
All right, this one's going to get me in trouble. But if you guys, if it's helpful for us to like join an initial conversation with the managed care plan, and it's not going to be like, 100 hours worth of work, just call us. Like, yeah, maybe Sarah's guiding me. No, but like, we're happy to join where it's not an overwhelming amount of time, these conversations to help move it forward. It's a really important moment.
Amy, go for it.
I just wanted to circle back on the template and the kind of the level of knowledge. I mean, I heard like that some people do, some people don't. And so I mean, are we just being fully transparent? Like this is something that has been developed to support this process. I mean, do they know kind of the general sense that we have kind of a response to help from our side as far as what we'd like to see out of this, or just a little help with the messaging? I don't want to like come down on have them feel like we're coming back at them like that they, you know, whatever they've proposed is not acceptable and like blindside them. That's all. I'm just trying to kind of navigate that a little bit. I mean, is it fair to say, like, I understand this has come down, like, this has been discussed with your organizations, and so sorry if you're not aware of that kind of thing, or
Amy, what county are you from?
Santa Barbara?
So your managed care plan. So CenCal, we've not interacted with. I think leading in with maybe a meeting before you send them the document, and leading just kind of how we led in with like the key principles instead of getting to know them is probably the approach that I would recommend versus lobbing over the MOU and saying without having an introduction to it. Because then you can lead in with like, these are the things that are really important to us in achieving through this process. We recognize that this is a learning process and it's going to take, you know, the relationship will take time to develop, and so we're going to send you some of our suggestions and want you to take that and consider them, but we recognize this is a negotiation and a collaboration, and so you can take a look at what we're suggesting, and you know, put your comments back to it. That's, I think, how I would approach it. I wouldn't send them the redlined MOU without a conversation first.
Okay, yeah, I can see that, and I think that's probably what we would do, but I just didn't, just kind of on the larger scale. I don't want them to think this is like our county's response versus like this has been something that's been worked on, you know, across.
Yeah, I mean, it's like you can always throw the consultants under the rug though too, right? Like, you have that in your back pocket of being like, and these like, you know, these consultants suggested this, but we don't think it's a good idea either, right? Like, I mean, there's some distance there that might help you.
Yeah. Okay. All right.
Yeah, I would definitely say throw us under the bus. Like some broke down bureaucrat from the Bay Area, like came up with some stuff, you know, that's fine to play it that way.
All right, thank you.
We sent this in February. Happy to send it out again. I should PDF it and put it in the chat, I suppose. But and we sent it to Children's Committee. I think the Caroline points of contact what we had on file, as well as child welfare our directors, our county welfare directors. And it was sort of intended to guide the question. Now, I appreciate this is like long and there's like a lot of bullets. And so this is probably really overwhelming. And maybe, you know, we need to distill this to like a one pager of just some bullets that reflects the MOU that we just got walked through. So, you know, for example, what's your vision, you know, for how are we serving kids and families together? What do you understand about the needs of our unique needs of our population? Like our population is very unique and specialized and needs to be, you know, treated with kid gloves, I think. Familiar, you know, going through like, do you even know what a 2083 MOU is? Like, you know, can we talk to you about what work we're doing with 2083? It's so awesome and we want you part of it. There's such an exciting opportunity there. How might we coordinate with other systems, especially those that you are entering into MOUs with? And just going into the MOU specifics, like, you know, do we agree that sharing basic outcome data is important? Do we agree that having aligned networks can be important? What's the value of that? So this, I know, is super dense. And so that's something that we can look at, maybe consolidating into some, you know, distilling into some high level bullet points for your discussions. Raise hands if you don't mind, those of you in the meeting room who have had a meeting with your managed care plan in your county. Excellent. We're start. Okay, we continue to have good. How's your meeting gone?
So I've been, Jackie House, Santa Clara County. I've been meeting weekly with our Santa Clara County Family Health Plan. They're the largest managed care plan in our county. And we have had good discussions. They have said they're learning a lot about the foster care population. We've sort of started looking at some data in terms of how many kids they're seeing that are showing the foster care aid code. I've talked to them about wanting to make sure that services are not just offered, but accessible and timely. And so we've been getting to know each other. And it's, Diana, I think in one message that you had sent, you said something about building a relationship. So we have focused on building a relationship. I've been very transparent with them that in Santa Clara County, we're waiting for additional guidance from the state and from CDSS and CWDA on how we should proceed. We're going to, and I did tell them, I met with them just yesterday. I told them that we have a statewide offering of a walkthrough for MOU. I didn't specify what the MOU was, whether it was, the same one that is a draft that is sort of publicly available, or if it's something else. So we've been working together to the point where now they have even started to reach out to me when they have challenges related to issues that they're seeing with either caregivers or foster kids as they come up. So, normally you work with the provider instead of the managed care plan. And now, and what I've found interesting is that the providers are contacting me about the same issues that the managed care plan is contacting me. So we're able to connect the dots a little bit better, right? Because we're not just hearing from one provider, because we have providers that more frequently serve foster kids than others, right? But at the same time, we're also hearing it from the managed care plan. So I feel like we're building a partnership. I do think when we get into the specifics, I've been very frank with them about what our foster youth need and the limitations that I have seen in the past with managed care plans in terms of what is offered as opposed to what is actually available in a timely manner. So, it's been a good discussion. We are not at the point of negotiating. When we get to the point of negotiating is when all of our niceties and that relationship will really come in handy, right?
That's right.
So
I think bridging the gap in how you define accessibility and timeliness, I mean, that is a huge win right there, right? And those are good things to build, good building blocks for your MOU.
yeah. And I think we have to approach the population, as Alex and you have said, we have to approach the population as beyond those aid codes. And that's where I get concerned is if we limit our discussions to those aid codes, because the aid codes are only a small percentage of the community. And in an ideal world, we should not have to open cases just to access services. especially not remove children to access services.
That's absolutely correct. I want to get to one more if we before we have time. Twyla, do you mind? I saw your hand up.
I actually was going to say something very similar, just that it seems like the providers are coming to us as well. So it's a repeat kind of comment.
Okay.
Diana, I could just add that in Tuolumne County, we actually have already, as a children's system of care, invited them to be members of our AB 2083 interagency leadership team and our advisory committee. So they're on board. And we are trying to see how we can integrate some of the stuff from the MOU into our CSOC MOU already. So I think we have a really good relationship with our two managed care providers, and we meet with them often. It's just
Michelle,
a matter of keep tweaking this stuff because there's so much.
You are the gold standard in that cross-system integration work.
Oh.
We may have to spotlight you and have your own platform on this because it's been quite impressive.
Oh, well, thank you. Thank you. Yeah, it's been, yeah. Anyway, thank you.
And Michelle, who are the two plans in your county?
We have Anthem and HealthNet.
And a number of other counties have too. Fantastic. Sarah, go for it.
So I know we talked about this at the beginning, but just to underscore as we're wrapping up, that in the multi-plan counties, it might be a smaller portion of your foster care kids who are in the managed care plan. And we've put in a request to try to get a better understanding of that data by county and to know how many are in of kids currently removed from their home in multi-plan counties, how many are in plan or not in plan. But perhaps I'll just plant the seed of for y'all to think about. You know, if you're in a multi-plan county and looking at your internal policies and procedures around managed care enrollment, do they need to be updated? Like now that you're sort of, you know, building this relationship and there are these potential new opportunities, is it time to also look at your internal processes around our kids coming in managed care and you're taking them out of managed care and putting them in fee for service, right? And then if so, why? And should that be the blanket policy, or should the policy perhaps switch, leave them in managed care, except in these circumstances? So just planting the seed for thought.
I am adding that to the list of our next steps because I think that is an important discussion and that may be some thing that we can lean into in terms of thinking through on a statewide basis how we support counties and give some guidance around that piece as well. We have a few next steps and we are tracking all of those. And so I wanted to thank you all for your time. Thank you, Sarah, and thank you, Alex. The offer is out there. If you would like some additional technical assistance, they are available. The materials we posted in the chat and anything that we haven't sent will be sent out. We have recorded this, so we will be able to share that out. If you want to listen to it again, or pass it along the recording to your colleagues, and we'll make sure that happens. I think with that, anything else I'm missing, Alex, Sarah, Baljeet, Andrea? With that, happy Friday. Thanks for your time. And remember to keep us posted on this.